Hello everyone, to today's edition of Cell Talk. Today we have presenter P. Uma Rakshita. She's going to present a research article titled Dietary Protein Intake and All-Cause Mortality Results from the Kawasaki Aging and Wellbeing Project. During her presentation, if the audience has any questions, please write those in the message box. Before starting the presentation, let me introduce Uma. Uma Rakshita is a research intern at Renix Life Sciences. She is working on multiple projects, including the gene maps and success of clinical trials. Gene maps involves data collection related to gene panels and a literature search for gathering information related to gene-associated diseases and their treatment. Success of clinical trials involves collection of information relating to drug details, scientific details, clinical trials, publications, and financial details of new approved drugs. She is also involved in organizing and handling the Cell Talk Journal Club presentations and other social media related activities. She has completed her Doctor of Pharmacy program from Nirmana College of Pharmacy, Mangalgiri. Before joining Renix, she worked as a drug safety associate in Pharma Council Private Limited for the project company Core Datasheet. At Renix, she has gained an opportunity to develop leadership qualities and to explore and learn new areas of interest. So I welcome Uma Rakshita to start her presentation.
Thank you, sir. Thank you for the introduction. Good evening, everyone. Today I'm going to give the presentation on the topic dietary protein intake and all-cause mortality results from the Kawasaki Aging and Wellbeing project. Topic selected is omics and longevity. This article was published in the journal BMC Geriatrics, which has an impact factor of 3.4. It is published on 9th August 2023. This research has impact on longevity, aging, and nutrition. First, let us discuss the background. So the relationship between the nutritional composition of a diet and health has been a major medical and frequent research topic. So when we want to discuss regarding this nutritional composition, we need to pay more attention to the quality and the quantity of the protein intake and from the source from which it has been derived. In Europe and the US, animal protein intake is associated with high risk of mortality due to cardiovascular diseases, whereas high plant protein intake is associated with low risk of mortality. Research findings on quality and quantity of nutrients in the diet vary widely due to some of the regional differences of the habits. For example, people residing in US have a habit of taking a higher percentage of fat, whereas people residing in Japan has the habit of taking higher quantity of protein and carbohydrates. And many studies also highlighted that the source from which this animal protein is being derived plays a vital role in health, like the animal protein that is being derived from red meat, red or processed meat contribute to high risk of death, whereas the protein that has been derived from fish meat contribute to low risk of death. In assessing the impact of protein intake and quality on health, it is essential to identify regional differences in food culture and examine the data carefully. Frailty is nothing but impairs activity of the daily living in older adults, and it is considered as a risk factor for the mortality in older adults. Studies also showed that increased protein intake helps in reducing the risk of this frailty. A study conducted by Mendonica found that higher protein intake by the population with increased physical activity helped to delay disability in very old adults who are aged above 85 years. Present challenges. Although the risk of frailty and the importance of its prevention have been widely recognized, there is still insufficient data on whether increased protein intake improves mortality in the age group most affected by frailty. And there were also lacking large scales that assess the protein intake in elderly population aged above 75 years, having no disability in performing their physical daily activities. Objective of the research to investigate the relationship between protein intake and mortality in Japanese individuals aged 85 years and above. methodology study population. This Kawasaki Aging and Wellbeing project is a prospective cohort study of consisting of older adults aged between 85 and 89 years, and they should not have any kind of physical disability performing their daily activities at the baseline. The inclusion criteria includes the participant should be a resident of Kawasaki city and should be aged between 85 and 89 years, and they should not have any limitation in performing the basic ADLs, and they should also be able to visit the study site independently. As of the March 2017, a total of 12,906 participants were screened as potential participants based on this registration of residents and long-term care insurance database. And from them, for individuals of about 9,976 individuals, they have sent the invitation to participate in the study. Among those individuals, a total of 1,464 participants had responded and showed the willingness to participate in the study. By the period March 2017 to December 2018, a total of 1,026 older adults have enrolled in this Kawasaki Aging Wellbeing project. During the baseline of the study, participants were evaluated for the physical, mental, and cognitive function, along with their active social participation. The participants were also undergone few tests like a medical examination, like BP, heart rate, etc. Physical tests like grip strength and the walking speed, carotid artery echocardiogram, hearing test, cognitive function test, measurement of muscle mass by bioimpedance method, blood test, urine test, bone density test, and spinal X-ray. And these participants were also scheduled for telephonic surveys for every 6 months to assess the vitals and also to note any incidental disabilities happen to the participant or any trauma from falls or fractures or any hospitalization, sudden hospitalization may occur for the participant till December 2024 or until the participant has withdrawn from the study. For every 3 years after the start of the study, the survey has planned to include the medical examination, physical fitness test, and echocardiography. Excluded participants, about 11 participants were excluded from the study because of insufficient filling of this BDHQ. It is nothing but a brief type self-administered diet history questionnaire, that is diet questionnaire. And 15 participants were excluded as the daily intake is outside the range of 400 to 6,000 kilocalories. And in a validation study of BDHQ in older adults aged above 80 years, the mini mental state examination score was 27.7. So in order to maintain accuracy with that score, the participant who has their MMSE score of less than 24 have been excluded from the study. So finally, a total of 833 participants were included in the study. Diet history questionnaire. The nutrient and food intake of the participant were assessed by using this BDHQ questionnaire, and it is it consists of 4 pages and includes 90 food items based on their food habits and the frequency of food habits. And it takes about 15 to 20 minutes to fill it of the past month. This BDHQ consists of 5 sections: a frequency of food and non-alcoholic beverage intake, daily intake of rice and miso soup, frequency and amount per serving of alcoholic beverage consumption, usual cooking methods, and general eating behavior. BDHQ also provide information on habitual nutrient intake, which includes intake of 30 nutrients and 50 foods of people residing in Japan consume from their normal diet. This below formula is used to calculate the total energy intake. And coming to the baseline characteristics, participants were interviewed regarding the basic some socio-demographic details and health data during the survey. And these participants were also questioned regarding the educational background, the living situation, smoking status, number of residual teeth, and the self-rated health. Medical interviews were done by trained physicians to note down any new chronic diseases like renal disease or diabetes, any diabetes, hypertension, or any cardiovascular disease have been encountered in the participant between the past and the current medical history. The BDHQ survey was conducted by several trained and experienced staff. ADLs and IADLs cognitive function were assessed using Barthel index, Lantern scale, and MMSE score respectively. The participants will have undergone some blood and urine tests such as serum albumin, triglyceride, low density lipoprotein, high density lipoprotein, C-reactive protein, etc. They were also their body composition specifically visceral fat was also assessed, and skeletal muscle index was measured by using impedance method. Mortality assessment. The plan was to collect the mortality information from a long-term care insurance system every 6 months and tabulate the data at a 3-year point. Statistical analysis. The participants of the study included in the study were grouped into 4 quartiles based on their protein consumption. Q1, the participants whose protein consumption is less than 14.7% of total energy, and Q2, the participants whose protein consumption is in between 14.7 and 16.7. Q3 quartile 3 for the participants whose protein consumption is in between 16.7 to 19.1, and Q4 for the participants whose protein consumption is above 19.1. All the statistical analysis used in the study were analysis performed in the study were done using SPSS statistics version 29.0, and a p-value of less than 0.05 was considered statistically significant. So coming to the results part, this table 1 shows the baseline characteristics of the study participants. If we can see from this table, the result shows that the mean age of participants was found to be 86.5, and there is an equal proportionate of almost like equal proportionate of the females and males. But as we can see, there is higher proportion of females taking higher intake of protein, and these females have a more number of residual teeth. The mean values of Barthel index and Lantern score were fell within the normal limits. Here, coming to the skeletal muscle index, it was found a mean skeletal muscle index was found to be 7.33. For males, it is 8.25, and for females, it is 6.45 kg per meter square. Muscle mass displayed the opposite trends. However, when analyzed by sex, no trend association was found between SMI and protein intake. Mean LDL value has been slightly increased, but it doesn't show any significant association with the protein intake. Table 2 describes the BDHQ results by the quartiles of protein intake. Here, the average protein intake by the participants was found to be 17%. For the participants belonging to quartile 1, have the protein 13.1, whereas it is 15.7 for Q2 participants, 17.9 for Q3 participants, and 21.2 for Q4 participants. As the consumption of protein has increased, we have observed that there is decrease in the consumption of decrease in intake of carbohydrate and increased intake of fat. And coming to the protein part, plant protein remained constant, almost constant among the various quartile groups, but the animal protein has been increased. Protein intake from fish was approximately 3.5 times high in the quartile group when compared to the first group. Here we can see in first group it is 20, and in the fourth group it is almost 68.6. So this graph explains the survival time analysis for the groups Q1 to Q4 during the follow-up period of about 3 point, during the follow-up period of 3.5 year. 29 deaths were observed in Q1 group, 31 deaths in Q2, 17 deaths were observed in Q3, and 12 deaths occurred in Q4 group. From this graph, we can see that this black line indicates the participants belonging to Q quartile 4, and they have higher, longer survival time when compared to the participants of Q1 group due to the high protein intake. This table shows the hazards ratio. From this table, lowest hazards were low hazard ratio was found for the participants belonging to the quartile 4 due to high protein intake when compared to the participants of Q1. For fish intake, the quartile 4 group had lower hazard ratio than with the Q1 group, and the trends for protein intake were significant. Coming to the discussion part, this study found that the increased intake of protein by the older adults aged more than 85 years with independent ADLs were associated with low risk of mortality. The results of the blood and urine analysis were within the normal range, and they didn't show any clinically evident, clinically problematic value. Results of group 4 have, when we observe the results of group 4, the participant has increased intake of protein, but we didn't find any significant increase in the parameters like albuminuria, urea, nitrogen, serum creatinine. Thus, there were no negative effects of high protein intake in quartile 4 group. Results suggested two mechanisms by which this protein intake affects the all-cause mortality. One is fish consumption and serum albumin. Fish consumption, the group quartile 4 group had highest intake of fish and had a significant lower all-cause mortality when compared to the participants of quartile 1. Usually, this fish is rich in N3 unsaturated fatty acids, some other constituents like essential amino acids, trace elements, and vitamins. These all constitute the property that helps to reduce all-cause mortality. N3 unsaturated fatty acid, these N3 unsaturated fatty acid has reported that they have anti-inflammatory property and also have the ability to inhibit carcinogenicity of certain cancers. They and also helps in reducing the onset of coronary artery diseases. Increased intake of fish lead to decreased intake of saturated fats, which are responsible for cardiovascular diseases related mortality. Albumin, coming to albumin, this study confirmed a positive trend in protein intake and serum albumin levels, which may help to reduce the mortality risk. However, the impact of protein and fish consumption on mortality is complex and influenced by multiple factors. Even after adjusting the serum albumin, fish intake contributed to lower mortality, likely due to other beneficial nutrients of the food. This study also suggested the beneficial effects of protein intake on mortality is independent of the muscle mass, as it included the participants who were who has no any physical disability in performing their daily activities, indicating other factors may contribute to the observed association. Limitations: no cutoff value was set for clinical use for the protein, and the cause of death were unknown. Shorter follow-up period was considered with few mortality events. Conclusion: based on this Kawasaki aging well-being project, the study suggests that high intake of protein in older adults who are associated with low risk of Based on this KAWP, the study suggests that high intake of protein is associated with low risk of all-cause mortality in lower adults aged more than 85 years with independence in ADLS, and these effects appear to be independent of the muscle mass. Impact of the research. This study suggests that consuming an adequate amount of high quality protein can help older adults reduce the risk of life threatening health conditions and improve their quality of life. Thank you, and you can find me at uma@renex.org.
Thank you, Uma, for that informative presentation. Audience, if you have any questions, please write in the message box. I don't see any questions. Can you please move to the next slide, Uma? Thank you. So next set of presentation would be given by Chaya YK, and her topic of presentation is cognitive function, healthy lifestyle, and all-cause mortality among Chinese older adults, a longitudinal prospective study. The presentation will be held on 5th March 2025, and we request all you to be present for this next presentation. Thank you.
Thank you, everyone.